Okay, my name's Harry Scarborough. I'm from the Centre for Healthcare Innovation Research at City University, and I'm delighted to be chairing this session today on exploring the complexity of spreading innovation in the NHS. Over the course of the next hour or so, we're going to be presenting the findings from a collaborative piece of work which we at CHEER undertook with two of the academic health science networks who've got the primary responsibility for spreading innovation in the NHS in the UK. I'm going to very quickly talk through the format of the session, and because we are very tight for time, I'll then hand over to our three presenters who'll be doing most of the hard work today in terms of presenting the findings from that study. I should say that if people are interested in a full account of the work that we undertook with the HSNs, then it's available via the HSN network on the website highlighted in the bottom right hand of that welcome screen. So just to move on to the format of the presentations today. As you see, we have three excellent presentations from Andrew Sibley, Wessex HSN. That will be followed by one from Alex Zeman from CHEER, and concluding with a presentation from Sarah Robins at Southwest HSN. We'll then follow the presentations with a Q&A. The Q&A will be based upon questions and comments that you as participants place in the chat. So please do use the chat function for any questions and comments that you have over the course of the presentations. We'll then focus the Q&A on those comments and questions. We'll then round off with interactive discussion. We'll use a poll to gather your thoughts and views on what you're hearing about the role of HSNs, and indeed the wider question of how you can spread innovation more effectively within the NHS or indeed other healthcare systems. Before I hand over to Andrew to kick us off, just a couple of quick housekeeping points. Obviously, you'll realize that this session is being recorded, but also particularly during the presentations, please remember to keep your microphones on mute. As I say, use the chat function or indeed tweet along at the HSR UK Twitter account if you want to add to the general discussion on this topic. But to begin with, I'm going to hand over to Andrew Sibley from Wessex HSN to kick us off. Thank you, Andrew.
Thank you, Harry. So it's my great pleasure to start this session with an overview of, well, introduction, and then to tackle that first issue about approaches that we investigated. Just quickly, the HSNs there are 15 of them across England, and collectively they're known as the HSN network, established in 2013, with a key goal to spread innovation at pace and scale and generate economic growth. Importantly, each HSN works across a distinct geography, some with one or two CCGs and trusts to support, others with many, and many levels, therefore, of complexity. They also, but importantly, they also connect multiple bodies, and we occupy this unique space of this sort of intermediary space between the NHS and academic organisations, local authorities, the third sector, and industry partners. And the staff composition of HSNs very much reflect that's those sorts of backgrounds. Next slide, please. Oh, I'm in control, aren't I? So I'll just hit the next one. Okay. I am pressing the arrow key, but it's not moving. Has it moved for you?
It has.
Okay. To introduce, the research took place over January to November 2020. This was to determine different approaches and challenges to spread and adoption across the network. This was a hitherto unknown topic. There had been lots of sharing between HSNs and a focus sort of inside each HSN about how to go about this work, but we didn't know what the aggregated view of that was really. So this was a great opportunity to do that. Firstly, we originally wanted to have a look at this between January 18 and 20, and we did, and that was in the sort of sense of business as usual over the preceding 2 years before the study started. But of course, the pandemic occurred, and so we pivoted slightly to also include an additional aspect of this study, looking at spread during the March to June period, which Sarah will talk us through shortly. The work was commissioned by the HSN Network and NHS England, a particular team, the Innovation Research Life Sciences team. And Harry's mentioned there were 3 study partners. An important part of this work was a large scoping exercise to understand what is going on, but we also focused in on one specific HSN national program, the Transfer of Care of Medicines program, which Alex will talk about in depth shortly. I've clicked the slide, just hanging, just waiting for it.
Try one more time.
It hasn't changed.
No, it hasn't.
No.
If you click on it and then use the arrow keys. Now it has changed.
Okay. So study questions. There were 6 we developed, and so what sort of different approaches did HSNs take? The contextual factors, which factors enabled and challenged those approaches? How theoretically informed were they, and did national policy frameworks influence those? And importantly, can we just pick one program and focus in depth on that one, the TCAM program, which Alex will talk to? And the 6th additional question, as mentioned, was about the spread during COVID, which Sarah will cover. Fortunately, all 15 HSNs participated, and we interviewed 143 staff out of approximately 600 or 700 staff across the whole network. And 18 of those interviews just focused on TCAM. Okay. Aha, that worked that time. So the way which from the interviews, we understood HSN's approaches at 3 different levels. First, the high level, as in how is it described on their website? How do they describe it to us as an overarching approach at their HSN? And we were careful to make sure we got that accurate. And these in the report, there's a list of each HSN and their named high-level approach, but they were able to be categorized into 4 different groups. The model for improvement from the Institute of Healthcare Improvement, a very strong force in the HSNs, perhaps unsurprisingly, because many HSN staff come from the NHS, and the model for improvement is very important in that space, and widely used and welcomed. And there's a very good evidence base behind that. One of the negatives, though, which we do cover in the report, of course, is that some staff may be predisposed to just focusing in on the model of improvement, and that might be a challenge if in fact there are other ways or better ways because of the context, to explore the innovation approach, the way in which you want to get innovation into practice. Another type was a flexible end-to-end broad framework. So this Oxford HSN, for example, had a 10-step approach, which was very, very broad in its focus. But the problem with those can be that there's not enough detail at the operational level, so that in terms of deciding what work we actually need to do to deploy these innovations. The third type was a flexible, but based on implementation science, and this was predominated by the Trish Greenhalgh's NAS framework, and it was often a popular. The NAS-CAT, for example, was a popular contextual exploration tool. And the final type was ones that were flexible, so they would use whatever was required, but which is a major theme throughout the whole work. But they did have a focus on coaching, and for example, Innovation Agency, the Northwest HSN have a coaching academy, in which they attempt to shift hearts and minds amongst their own staff and staff in the innovation rollout sites. with all that variability in mind at the high level, there were some very common principles across all 15 HSNs, those being that they were very engagement focused, and that they worked with the needs of the health systems. So it was quite often a bottom-up experience. We were trying to support local problems and thus ensure that engagement. Building and using networks, absolutely vital, and a common principle across. And looking to seek and sustain that spread rather than it being a short transactional experience. And the fifth principle was around having a common persona. We noticed that we do occupy this intermediary space and that we have a way in which we approach and work with our colleagues. At the project level, I'm not going to go through all of this at all, but there were different types of mental and physical work which were described. For example, we're planning activities, understanding that innovation, understanding the rollout context, really important to do that before you get going in order to shake out any potential problems so that you can mitigate for them. An interesting project management approach was this idea of a trio approach of wrapping around the innovation and expertise on implementation science or QI with project management, with clinical expertise as well, wrapping that security blanket, that safety net around. My slides are moving.
Apologies.
I didn't touch anything. Okay, well, that's okay. Those different descriptions of work lead into this slide anyway. When considering the dozens and dozens of types of activities and pieces of work that you could do when it comes to rolling out innovation, at the project level, these can be grouped together into types, one of which was the long collaboration. So for some of the national programs, which are mandated down from NHS that we are asked to roll out, often we need to engage in long collaborations to set those up because they're complicated pathway changes and they require a lot of support and work with the local sites to make that happen. Another type was system partner needs led. So this is the reverse really, where we might wish to, the approach is to support them with locally developed innovations and solutions to local problems, often in the form of pilot and demonstrator sites. But a challenge to these addressed in the report are potentially if there's no national impetus for this type of thing, then it can have problems. So there are pros and cons to each of these, which are covered in the report. The third type was innovator-led. This was less seen, but it is an approach whereby we hand over rollout responsibility to the innovators, but there are pros and cons of that as well. The particular con being that the innovator may not share all of the issues with the rollout site, so we often occupy that honest broker space. And finally, targeting specialist services. This is, we have a mandate to roll out rapid uptake products. But these are very well evidenced innovations, and we're looking to push these out rapidly because we know that they will be valuable. And so this constitutes an approach, and there's a combination of work behind this to try and do that quickly. I'm going to move on.
Are you into your final slide now, Andrew?
Yes, this is my final slide. So just to summarize, there were a range of different approaches, principles, and specific spread activities were uncovered. And this is good because it creates more visibility that wasn't there before across the entire network. So that's an important point and covered in the main report. Understanding approaches matter. Despite some innovations being intrinsically simple, we certainly have lots of experience of the context and people and pathways make those simple innovations more complicated. So thus a spread and adoption tends to be complicated. A major theme from the approaches work was there was no one best way, and I think that's an important but hard message to hear for people looking for solutions. Flexibility and adaptability perceived as very critical to spread, particularly with the hundreds of innovations HSNs are trying to roll out across a complicated network of hospitals and primary care. And finally, learning from this diversity in this review can add to increasing the knowledge and adaptability of each methodology by supporting partners to spread and adopt as effectively as possible. So more learning required. I'll hand back to Harry. Thank you.
Okay, thank you, Andrew. Obviously, one of the implications of Andrew's presentation, as he highlighted in the final slide, is spreading innovation is inherently a complex activity, and we know that there is no one best way because it's so context dependent. And that really begs the question from a research point of view of how do you establish what works and what doesn't work? How is it possible to identify what the real, cause and effect relationships in the way that innovations are spread? And Alex Zeman now is going to talk us through another strand of the study, which really highlighted that question and tries to address it in a forensic analytical way by focusing on one particular program, which the AHSNs were committed to. So over to you, Alex.
Thanks, Harry. So I'll be presenting findings from a sub-analysis that we did as part of the wider study that Andrew just presented on. And that was comparing approaches applied by the AHSNs to spreading the same national program called Transfer of Care Around Medicines, or TCAM. And we were interested in finding out what approaches were linked to successful spread. And we tried to answer that by applying a qualitative comparative analysis. I'll explain a bit more what that means in a second. So TCAM is a digital pharmaceutical innovation, a software to facilitate data sharing on medications of patients that were discharged from hospital to either the patients dedicated to community pharmacies or in addition to their general practitioners. And this innovation was spread over 2 years as an official national spread program across the NHS in England. We applied a mixed method design in this sub-analysis. So in the first step, we have identified strategies used by HSNs to spread TCAM by applying a qualitative thematic analysis to interviews conducted with 18 staff members at all the HSNs. So this is a subset of the 143 interviews that Andrew was talking about. And in the second step, we have identified the success rate of each HSN for spreading TCAM in a quantitative analysis of national outcome data. And the third step then combines the results of the first two steps in a qualitative comparative analysis. And QCA is a type of a set analysis approach to identify what are key strategies, key essential strategies to spread TCAM. So to the findings, I'll start with the quantitative findings. They show how successful the spread was across the 15 HSNs in England. And this data is reported by each HSN to the so-called national dashboard, which is run by the HSN network. And success was defined by the HSN network as at least 50% of acute trusts in an HSN area having adopted TCAM. And we can see that about half of the HSN had reached this threshold towards the end of the national program period and our analysis time period. So you can see in lighter blue are the successful ones and the darker blue ones are the unsuccessful ones. So we can also see, if we move on to the future that we didn't analyze, that the trend goes more towards the more of an adoption. So here about 80% of HSN had crossed the threshold and had successfully adopted TCAM about half a year later. So this system map is showing the qualitative themes of the most important contextual factors on one hand, determining the spread of TCAM, and on the other hand, related spread approaches applied by the HSNs, and based on the themes that we could identify from the interviews. And you can see the key contextual factors in blue on the right-hand side and the spread approaches in red on the left, and how they are interlinked and related to each other indicated with the arrows. And I'll start with the contextual factors, and below here on the bottom right, you can see the outer or external context domain, so national context factors. And with TCAM being a national spread program, that's not a surprise that this level has huge importance. So there was a national leadership team for the TCAM, for the national program, and they provided the local HSNs with guidance and support, and they saw that as very much an enabler of their own spread work. Another category of the outer contextual domain is the regional health system focus, and we saw that in Andrew's presentation, how much that is the focus of any HSN work. And here the need for HSNs to help fit TChem into the different local contexts. And I'll show some quotes during this mapping exercise from the different interviews in order to illustrate our findings. And this one reads, so you can't have a blanket approach. As much as you might have a one-size-fits-all project, there are local variances and local barriers that we need to address. And our role is to facilitate the appropriate discussions with the appropriate people to try and come to a win-win for all. That is basically how I understood HSN work to be in a nutshell anyway. So interviewees highlighted here at this regional level, especially in existing networks that they could tap into, and found that as an enabler for spread of TChem. And on the other hand, a barrier in the fact that some HSN areas or some NHS organizations had already used TChem in the past and had some negative experiences with it, and therefore were not very happy to try and implement it again, and that was a barrier. Interviews highlighted some innovation characteristics that were having an enabling influence. On one hand, there was some scientific evidence around TChem that was really working to convince local stakeholders to adopt TChem, and some flexible software arrangements that helped to adapt the innovation to the local context. So moving on to the key spread approaches responding to those context factors on the left, we had some activities around dissemination and capacity building, and these were based on one hand on the scientific evidence and the guidance that the national team provided, but on the other hand, this is linked to another set of activities that so HSNs really saw the need to produce localized evidence in the form of setting up local pilot projects and demonstrator sites, and having them use TChem and implement TChem as a first early adopter site and prove that there is local impact to be had and that TChem is feasible to implement. So that was quite a key activity for HSNs. And this is illustrated by this quote. So if something's brilliant on the Isle of Wight, somebody in Blackpool will go, well, that's the Isle of Wight. That might not work here. So there's really something about this first site up and running. Another key spread strategy was around financing. You see that at the bottom here. And HSN, for example, paid for the setup of pilot sites or paid for software licenses. And while HSN staff reported that they found this a very helpful strategy to initiate adoption in the first place, they found that in the long run, this was rather working against sustaining TChem because, and this is what this quote illustrates, who will take over the payments after the initial implementation program period? That are not really structures in place that facilitate a long-term sustainment of innovations that HSNs help to spread, and HSN staff were telling us about that as a barrier. Another set of activities was around relationship building, and as Andrew mentioned, this is really also a key activity of any HSN spread work, is to build relationships with local stakeholders, and this is no different for TChem. Important here is though, and this is related to the structural activities, is who is leading on the HSN side, who is leading the spread approach on the HSN side, and who is building these relationships. And this was not champions or implementation practitioners or project managers for TChem, but it was senior local pharmacists that the HSNs employed on a part-time basis that led the spread of TChem. And if HSN did that, they were really successful and saw that as a key enabling factor or strategy. And this quote would illustrate that. So these people were really known in the system, were respected by the local stakeholders, understood the innovation, understand the local context, and they speak the same language as the stakeholder. And therefore it was much easier for them to build these relationships and engage stakeholders in the spread process. I wanted to take you back to the national level and coming full circle really, to highlight the key driver for implementation and probably also long-term sustainability of TChem. So towards the end of the National Spread Programme, the national contractual arrangements came into force that are now mandating the use of TChem in hospitals and in pharmacies. And so HSN staff were telling us, well, if this would have come into force at the beginning of the programme, that would have really saved them a lot of time and effort. So which of these particular spread strategies that HSNs applied to spread TChem could we now identify as being essential to success? The qualitative comparative analysis analyzed if a qualitative interview theme for a spread strategy was linked to a successful or an unsuccessful spread outcome as derived from the quantitative outcome data. And we compared that across each of the HSNs, and the QCA then gives us a result for that of this comparison by applying Boolean logic. And we compared 4 major strategies that you can see on the left-hand side. So the first one was if an HSN employed a pharmacist as a lead spread facilitator. The second was if an HSN engaged in spreading TCAM before it became a national spread program. The third is if there was a delay in starting the 2-year national spread project. And the last activity was if the HSN applied an intersectoral approach towards engaging all the stakeholders at the local level. And the qualitative comparative analysis then showed that a combination of 2 of these activities, one of them being the non-delayed start into the spread project and the other one employing a local senior pharmacist, together were the key success strategy. So HSNs who have done either one of those activities or none of these activities were unsuccessful in spreading TCAM, and all of the HSN who did apply both strategies were successful. To summarize, so the HSN spread activity for TCAM was characterized by an adaptive, localized, whole systems approach to successfully embed TCAM in the different local contexts, and matching the role and expertise of spread staff to the program's clinical focus, in this case, in combination with engaging early in the spread process, was identified as the key spread success strategy.
Okay, thank you, Alex. I'm now going to turn control of the slides over to Sarah Robbins. One of the things that you might have noticed so far from the 2 presentations is we haven't mentioned COVID-19 at all. This is not to say that COVID-19 wasn't important. Indeed, it was a significant challenge for actually conducting the research for this study. At the same time, it also meant that we were able to view the way that HSNs responded to COVID-19 on the ground in real time. And that actually provided a further strand to the work which Sarah Robbins is going to talk about now. So over to you, Sarah. Thank you.
Thank you, Harry. Right, see, I've got the slides going. That's a good start. So yes, as Harry was just saying, of course, as we all know, COVID hit when we were at the point of this study where we were beginning to do some of the interviews. We found some initial findings were coming out, having some interesting conversations, and then of course everything shifted. And so we thought it was particularly important to look at what was shifting and what were HSNs doing differently, if anything at all, as a response to COVID-19. What did it mean for them that the context within which they were working was shifting, and what were they doing differently? So looking at what was happening that was different, but importantly, how it happened. What were they able to do differently? And then what can we take from that to learn to feed into the future AHSN spread activity? So we did a series of focus groups. We had 14 AHSNs participating in them. And from that, we just pulled out some key findings, which we've then we fed into various different reports, as well as this one, in different bits of learning around what happened during COVID. What did those shifts in the ways people work and the things that were happening mean generally for work within the NHS and within the HSNs? So one of the first key findings obviously was about the fact there was a shift in our national context, and that had a substantial impact on the way in which the HSNs could work. And in fact, it had some really positive impacts on those key elements around spread. In particular, we've heard about the importance of engaging with the people with whom the HSNs work. There were certain systems that were put in place. There were, for example, the sales structure that happened, which actually increased the opportunity for engagement and partnership. So there was a more collaborative working across the system, and HSNs were often invited into those conversations, which allowed us to have better engagement. There were more rapid decision-making processes. As we know, things had to happen very quickly, and different systems put in place structures to allow decision-making to speed up. And generally, this is one thing we've seen across a lot of the other learning that we've done around what happened during COVID, was there was a shared purpose. There was a shared purpose that gave impetus to the need to change and adopt new ideas. So often those things that we would come up against where there were multiple people with different objectives, which is often a barrier to spread, you had teams of people who were wanting to see something to happen and wanting it to happen quickly. And all of this helped open up channels for spread to happen. And as one of our focus group members said, it was really about the sort of urgency within the system. There was a bit more risk taking, a bit more less risk aversion, and talked about the need to put in governance around that. But generally, there was a shift in the way that people were working and the cultures within which they were working, which actually facilitated spread. One thing HSNs did as well was to use a range of responses. So there were 3 different ways in which they worked. There was, in particular, responding to the acceleration of existing programs or innovations. So identifying what was already in place that would really help the system locally to them, And what were those things that they were already seeing that they could accelerate the spread of and accelerate engagement around, identifying new ways of working and rolling those out, and then really looking at what the needs were, what were our member organisations in our region seeing, what would they really need, and what could we do to help that in terms of identifying approaches and innovations. And it was really about taking, as it said in that quote, an agile approach, not being too prescriptive, so not saying we have got this thing and it needs to work in this way, but really thinking about how can we take things that were already there that could be adapted, and finding ways for them to meet the needs of what was going on at the time. There was something about the impact of the very reactive response that AHSNs had, which actually ended up enhancing relationships within the system. And that what was seen there was that there was a combination of accelerated spread. So as I said before, we had accelerated spread, existing solutions, really getting out there and understanding what the needs are, what have we got that could really help there, and getting that to happen quickly. That helped us to work more closely and built up those relationships better. And we got a sense feeding back to us that health services felt listened to and were worked with rather than done to at that time. So there was a real shift in the way that the HSNs worked with the system. There was a really strong focus on getting out there, on understanding what the need was, and on adapting things to meet those needs in a very accelerated way. As I say, acceleration, there was a speed and a flexibility of offer, and that became really important in the support that was given. So there was a whole thing about introducing innovations, as I was saying, so going out there and saying this could work, why don't we give this a go? There was a lot of testing that went on to put things into practice more quickly. There's that whole thing about, spread works best when people can really try something out, they can test it within their own setting. And there was a lot of that was happening in the early stages of COVID. And then there was something about being reactive to the needs of the health system, rapidly changing their own ways of working. So the HSNs were being extremely responsive. I mean, HSNs are responsive, that's how they have to work. But in that early stage of COVID, there was a real shift in that responsiveness. And as somebody said, we literally just hit the black book and thought, who can we call? Who can we say, clearly you have different needs right now, what are they, how can we help? So really getting out there and being proactive. One of the elements that was picked up quite a lot was how, what do you do about collecting evidence around this? When things are happening as quickly as they were. So AHSNs, one of the things that AHSNs do a lot of is use of and actually collecting of evidence. I'm an evaluation lead, Andrew's an evaluation lead. There's something that we do in AHSNs very well around evaluation and learning. And we have sort of longer term evaluation plans. We evaluate the work that we do. We work with innovators. We work with different project streams in order to do that evaluation. And of course, when these rapid change was happening, what did we do? What could we have done about collecting that evidence? And there was a sense that there wasn't really the time to do that at the same as this was going on. But there was really a recognition that there was a need to continue to collect that evidence. And that what we were doing as we went through was collecting what we could so that you had the evidence for outcomes and process to ensure patient safety, of course, which is vital to everything we do, and to create sustainable adoption options. So often the need for that information to be coming back that could be built into business cases that commissioners could use. If they try something out during COVID, is this something they want to continue? But you need that evidence in order to make those business cases going forward. So as that quote is saying, it's really important when something has happened really quickly. Make sure that we're doing what we can with the system to extract learning at every possible moment. So really keeping up with that. We did a lot of rapid learning collection during COVID. It's something that AHSNs really started putting into practice, is putting rapid learning loops into work so that we could really pick up on what was going on. We could learn from the changes that were happening and put sustainability in place where it was most relevant. Strengthening relationships and system understanding. So as I said before, there were some positive impacts in terms of the links and in terms of relationship building for AHSNs during COVID because of this sort of rapid, flexible, very engaged kind of work. But it wasn't just between AHSNs and the system, it was actually also between AHSNs. There was a lot more collaboration that happened between AHSNs, which is something which is continued to be seen and which was extremely positive. And there was a real sense of the importance of understanding context. I mean, we've said this for a long time in the spread world, that really putting the time in to understand the context is really, really vital part to the early part of a spread project. And COVID really demonstrated that in the early months, because you really had to be fully engaged in understanding what was going on. And then really, as this quote says, communication is obviously vital, relationships are important, Don't ignore the culture and local politics. They're really important. Align your incentives. So working with your system to help them do what is good for them. That's what the spread thing is. It's about helping people to do what is good and helping them to achieve their objectives, rather than pushing against a brick wall and saying, we've got this great thing, you should do it. So just picking up on some of the key elements there from this bit of the COVID study, the sub study that we did. What we found was, there is a need to sort of consider the value from different communication methods, including digital. I mean, early on, it was pretty much all that anybody could do, and it did build up great opportunities for more conversation between parties who might find it otherwise difficult to get in touch with each other. We found going forward, of course, that digital is not the only way of communicating, and we need to temper that a bit. But just there are different ways of communicating which can open up relationships, and that's something important to build on. And of course, building on the positive interorganisational relationships that have built up, and really recognising the value that was had in working flexibly. And one of the things that we saw was AHSNs having teams who could adapt to meet the changes within health systems. So having different people within teams who could do different things to meet those needs in different ways. So thinking about the team structures for spread, really important and something to be built on. Sharing learning was something that we saw a lot of in the early months of COVID. So people recognising that, they didn't want to go this alone. They wanted to learn from others who were also working in similar sectors. And one of the things that many AHSNs did was bring people together in learning sets so people could share what they were doing, and they could learn from each other. And that's something, of course, to be built up going forward. And finally, it really understand that focus on context again, really understanding that those shifts in context within people, the way they were working, relationships, structures and processes, all those things influence spread in those early months of COVID. And it's something to continue to gather evidence about, really focusing on that understanding of the context of how people work, of how they communicate, and really using that kind of evidence and continue to gather that evidence to help with spread going forward. So that's the end of my little sub-study. And I think this is just a slide just to bring us to the end of this beginning presentation bit, really, to really just think about how do we bring those three bits together, and what learning can we take forward for the different stakeholders that were involved in this. And the first lot of learnings we got up there are for AHSNs themselves. And there was something we saw throughout the study and throughout the sub-studies as well, is about really understanding, getting HSNs to understand more about different types of spread methodologies. There are different methodologies, and there's something about really getting to grips with what those are, and being a bit more focused on understanding those and unpicking them a bit more. And again, building on that, sort of supporting the shared learning across AHSNs, making tacit knowledge more explicit. We talked about possibly having a repository of learning, which would be really focused on what happens with the different spread approaches. So what have you tried, what worked, what didn't, and building up more of a basis for understanding what spread looks like in practice. There's something about the using diversity of spread and adoption experience of different staff in AHSN. So we have staff in lots of different settings, and they have different experiences, and they have different understanding of the context within which they've worked before. And those can actually be extremely helpful when thinking about project teams for doing spread work. For the wider health and care system, we've seen in particular that there is time that needs to go into doing spread and adoption work. There needs to be consideration made of, if you want this to work properly, it needs to be resourced, it needs to be given time. And you need to really think, especially about the availability of clinical staff and champions within settings who are so important to allowing spread to happen within NHS settings. So really giving that time. And again, thinking about the timeframes again, improving the alignment of timeframes between rollout projects and national policy levers as key enablers of spread. I think that TCAM was quite a good example of that. And there's something about targeting long-term sustainability instead of short-term adoption as key performance indicators. So there's a difference between getting something to be implemented in one setting and it being fully adopted. There is that difference, and that's something that we tend to reward and look for it to be spread in a certain number of sites without thinking about the long-term sustainability. What does that mean? Because if you're going for long-term sustainability, you need to consider how it's built into an organisational system, into processes, all that kind of thing, rather than it being a short-term implementation project. For health services research, we were thinking about the possibility of thinking more about the link between spread approaches and different types of innovation. and different stages of the rollout process. So unpicking that a bit more. So what does it mean at those different stages? What do we see when we think about how different types of innovation work in different settings, and what do we need to know about that a bit more in order to think about what spread is needed, what type of spread approach is needed? We saw about the different frameworks that we used, and so there's something about the role of common normative frameworks and scientific theory to guide spread practice again, so creating more of a structure around some of that. And the role of codification of knowledge and evidence in improving spread across diverse contexts. So really, again, unpicking and making clear what does spread actually look like, how does it actually work? Again, we talked about sustainabilities, which strategies are more effective in spreading innovation sustainably. And going back to what I've just said, it's not quite the same thing. Implementation, putting something into place is not necessarily the same thing as having a long-term spread and making it sustainable. And finally, exploration about how to marry the requirements for evidence and pace of change, and the role development of rapid spread approaches. So this links to the COVID study in particular, where we saw very rapid rollout, very rapid spread, but also we needed to temper that with the need for collecting the evidence, keeping the learning gathering going as we went through it. So yes, thank you. So that's the key conclusions against the whole thing. And I'm going to hand you back over to Harry now.
Okay, thank you, Sarah. And obviously at this point, we want to open up the discussion to all the conference participants who want to contribute at this point. There's a lot to take in from those presentations because they each highlight different aspects of what was a very large-scale study. But while people are kind of getting their heads around, particularly the final slide in terms of implications of the study for different stakeholders around the NHS, I just wanted to get the discussion going with the question, I think, initially to Sarah as the most recent presentation, because clearly your presentation, Sarah, highlighted the change of the improvements actually that the HSN's made in the way that they worked in response to COVID. And I suppose there's an obvious question there in terms of what kind of change was undertaken there. Is that something which is a temporary, a grudging adaptation to a very dramatic change in the context? Or are these changes, are these improvements in speed and flexibility that you talked about, are these really sustainable longer term? Are they baked in now into the way that the HSNs work?
I don't know if I could answer that for all the HSNs, or I should just answer that for my own, or if that's dangerous. I think there's something to be said about when we were talking to our NHS colleagues at the time, that they were saying that they were sort of almost freed up to do rapid things and to change things rapidly in the early stage of COVID, because there were certain other elements of their work, certain commissions, certain things they were supposed to put into place, which they didn't have to do anymore. And there was definitely something about the fact that AHSNs, there were some of our national commissions, they were still happening, but the focus was really totally on supporting the local system in order to respond to COVID. So we had the same shared purpose as the system at that point. But I mean, my perception is that way of working, there was a lot of structural changes that happened. I think definitely within my organisation, but I think in others as well. The ways that people worked and the teams and the way that the workforce, all that kind of thing, that actually did change. And what I'm seeing is that some of those changes are continuing going forward. And there is definite recognition of the importance of those relationships that were built up within the system in those first few months. And those are continuing, those relationships are continuing. And there's easier ways of communicating. And I think AHSNs were seen as actually being very useful. I mean, we've heard that quite a lot. They were really, it was a moment when it said, oh gosh, this is really, really helpful what you can provide here. So that is continuing to be the case.
Okay, great. I'd maybe just pass that question on as well to Andrew to give a perspective from a different HSN and whether you see the same things that Sarah's saying.
Yes, I think quite similar. I think it's really important for HSNs not to be seen as tone deaf to the NHS. We need to pivot when they have major problems and priorities, and when they change, and they will change. It's part of a highly complex dynamic system that the NHS is, and I think that that's part of the reasons why we moved and supported as we did. I think from a spread and approach point of view, it started off at Wessex a great re-examination of how we go about spread and adoption, and this report and this work, and I think that's going on in many different HSNs as we speak now. So workshops to engage staff who up until now have been disengaged from the idea that they're involved in spread. Perhaps staff who occupy niche positions like finance and communications, when in fact they're very much embedded in it, but just in a slightly distant way. So it's been really good. I think a really good experience, and there's lots and lots more to learn from diving into this in more depth.
Okay, that's great. I'm going to give people a bit more time to reflect on the presentations. As I say, we covered a lot of ground with those three. And if people do have any comments or questions, then please speak up or raise your hand so that we can take that comment or question. But just while we're doing that, one thing I think is worth revisiting from an earlier presentation, from your presentation, Andrew, was your description of the different approaches that the HSNs take. This is something that's a really important finding from the study, I think, which is that each HSN does things in a different way, that there is significant variance across the HSNs, the way that they approach the common task of spreading innovations. And I just thought it might be helpful if you unpack what's going on in the way that these different approaches work for each HSN and what the implications are, for spread itself. Does it make a difference that different HSNs take different approaches? Perhaps we could just revisit that particular slide on the 4 approaches that you talked about.
Who has control? So on just to start off, each HSN does occupy a unique. I think you're looking for the Alex. You're looking for the that one. Yeah, go back that one there.
Yeah.
So each HSN occupies a unique patch. So it has a different geographical region, and they also have different combinations of CCGs and acute trust to support. And whilst there were 7 national programs to support during the study timeframe, there are many different innovations, hundreds of innovations being chosen to roll out locally, which may be different from others. So the contextual complexity is considerable, and I think so. Perhaps it's no surprise that HSNs have gone about it in different ways to succeed.
But did those different ways have an impact on the way in which innovations were spread? Did it mean that, if they had a model for improvement approach, that meant they focused more on incremental changes? Or did it mean that, different types of innovation were selectively spread in different HSNs, or the speed was different? What were the implications for the spread of innovation itself?
That's a very tricky one to answer. I think there were the implications for spread itself. I'm not sure. I think they're so complicated, that question. Does anybody else have any thoughts, Sarah?
I'm just thinking about the different elements of that were in those models, and the fact that people use different parts of those in different settings, like you said, Andrew. So, for example, where I am, model for improvement, people use for some of the clinical patient safety kind of programs a lot. But in fact, we use some of the model for improvement elements in some of our wider spread work as well. I think within this, so I think when we looked at it, there were it's a patchwork of lots of different methods within different settings. And I don't think that this study took us to a point where we could actually say, well, this bit resulted in that happening. I think that is for a future study kind of response.
That's the kind of thing I love to hear, Sarah. Further research is needed.
Further research is needed, Harry. That's the answer.
Always the best conclusion from any study. So perhaps we should move now, because we also wanted to conduct a poll with the participants for this session, just to get your responses to some of the key elements, some of the key thoughts coming out of this piece of work. And maybe this is a good time to launch that poll and give people a chance to respond in terms of their views and their opinions. So we're just putting a poll on screen now, which really highlights some of the different activities and strands of work that the HSNs do, and is essentially getting your view on what's the most effective way in which you can encourage the spread of innovation in the kind of very complex environment that we've been talking about that the NHS poses for innovators and adopters. So we're talking there about a range of different activities, from whole system stakeholder engagement, senior level support, adapting the innovation to a local context. Is it important to support innovation through seed funding, for example? Is the front end of innovation neglected? And is there a need to generate local evidence? Do we need to really tailor things to a local context? And we also have, a kind of further concerns there about who's doing this and what kind of skill set do they have? Do we have enough capacity in the system to support what can be a very challenging process of adopting and implementing innovations? And what kind of, mindset or skill set does it take to be effective as someone as a facilitator of spread? The people who work in HSNs, what makes them effective in their job? All right, so we've got, and we're starting to get some very different views here emerging on that kind of pull. Interestingly, seed funding is getting a lot of support, which is interesting, because that's really, in my understanding of it, is much more about stimulating the development of innovation, more than necessarily encouraging its spread. But I suppose it depends on the way in which that seed funding is supported. So is it about supporting the innovators, or is it more about supporting the adopters through local evidence and adaptation? So those are the kinds of trade-offs, I think, that emerge when you talk about spreading innovation. Even if we accept that there isn't one best way, clearly there are trade-offs in whatever you do to do this. Okay, I think we've had enough time to reflect on that now, and we can actually just very quickly review those findings. Interestingly, very little emphasis given to capacity building or the skill set and development of the facilitators themselves, which suggests that people feel that the HSNs kind of already have the tools they need to do the job, and that the challenges lie in other areas. We did have a comment though, which I'll maybe pick up on from Julian Baker, who said, rather than spread to scale, perhaps there's merit in terms of making the change at scale. Is that something that you guys would agree on, the presenters? Would you like to chip in on that comment?
So I'm just picking up, trying to work out, so you mean the difference between taking something, so you've got your prototype, you pilot it, and then you get to your spread point. So you're spreading it, and by going through spread, you're then doing scale. You're then going to be scaling up in terms of numbers that way. You're saying that that's different from scale, from taking spread and going straight to making your change at scale. Is that what you mean, Julian? I see you've unmuted.
Am I live on screen? Yes, that's definitely what I mean, because people don't like something unless it's built around you. So why don't you build is building it for emergency departments from the ground up. So building it with them, and then they can't look at it and say, well, oh, I'm pinching something from there. What you were doing is some of what you're building is greater than the individual parts. So you're taking little bits from everywhere. And when it comes out as an output, there may be a way of identifying their component in there. But it's such an impressive output we found that everybody wants to buy into it.
So it's like a massive co-production kind of event.
Co-production, collaboration, yes, from the ground up. So they got a skin in the fight then in the game. Yeah. So that way you're saying you then skip that whole bit that we talk about with spread, where you have to engage people in your idea, because it's not your idea, it's their idea right from the start, but you're doing it. Yes. Yeah, and I think that's sometimes when people look, well, it doesn't work. You know all of that. The evidence suggests that. So why don't you skip that and go to the building at scale? It takes a lot of energy and collaboration in that space, but it's about hearts and minds. And I just wonder if there's something there about the difference between taking an existing idea and spreading it, and what you're talking about there is almost co-producing from new, but or are you co-producing around something that already exists? It's to coin the phrase we're using, it's designing what good looks like. but it's designing what good looks like from the ground up.
Yeah.
Well, there's then something different in terms of putting it into practice, which is the how, which you can get into making it happen locally, because you have to undertake locally, maybe variable, but the building and the design of good is a collaboration.
I mean, I think there's a really interesting point there that your comment connects to, Julian, which is how you develop the innovation affects how you spread the innovation. The two things are connected, and if you develop the innovation in a bottom-up way, then it's more likely to find acceptance and support when you try to spread it than if you do it in a very top-down way. So I think that's a really interesting insight that comes from that. And maybe that goes along with the comment that people are making there about the importance attached to seed funding, which received the highest support in our poll. I mean, I don't know if anyone who actually voted for seed funding as the most important aspect of successful spread. Would someone like to speak to that and say why they supported that view? There are obviously in favour of getting the seed funding, but less vocal about supporting it on the forum like this. But clearly, that's something that people do need to take into account in terms of how innovation is supported as a process from its origins and the way in which it's developed right through the way in which it's spread. And clearly, it's easier to mobilise support for an innovation which has already been developed in a bottom-up way, with or without seed funding, than try to do that in innovation which is being implemented in a top-down way with perhaps less support and less acceptance on the ground. Okay, did Andrew and Alex, would you like to comment on the findings from that poll there in terms of how that relates to what you're finding in the study in terms of particular aspects of HSN work?
Just one point on seed funding, that HSNs traditionally have not provided that funding for innovations. In my experience, it's more about supporting the local rollout partner to develop a bid or a grant or some application for money to support a member of staff or backfill or something rather like that so that they can do the rollout. And we in Wessex, for example, we have a bid writing expert who can support that. Okay, all right. And Alex, would you want to comment on the poll findings? Clearly, this is giving us a different view of what's important in spread compared to the kinds of things that come out from the HSN study. But clearly, we're looking here at the kind of whole system aspects of innovation, aren't we? Do you want to comment on that, Alex?
The whole systems approaches, yes. Mm-hmm. I guess maybe it wasn't clear what we meant by that, but I do think everything HSNs are doing is kind of on that basis, on trying to serve a whole system and engaging and spreading something across the whole system, because that's the level they work at. So it's not only about stakeholder engagement, but in really taking that perspective in order to bring the different components together, understand the context, integrate all the stakeholders' views, and try to make something work with different organizations and not just one. So I think it's what HSNs are all about.
Great. Well, what HSNs is all about, that's probably an appropriate statement on which to end this workshop session, because that's really been very much the focus of what we talked about over the last hour. I want to thank Alex and Andrew and Sarah for their great presentations, and also yourselves, participants, for contributing to the discussion in this session. We're on a very tight timetable, so we have to draw this session to a close. But as we've highlighted, we're very keen to connect with people who are interested in this area. Whether or not you think we need further research, we're always happy to explore that possibility. And indeed, if you look at the slides, the final slide gives you further contact details to explore that area of interest if you want to do so. But it just remains for me to say thank you very much, and many thanks for involvement in the workshop. Thank you.